Great. Well, thank you, Erin. Again, my name is Neera Goyal, and I'm a primary care pediatrician and newborn hospitalist with Nemours and located at our Thomas Jefferson campus in Philadelphia. So I'm just going to present a little bit of research that I've been focusing on related to primary care of infants with intrauterine opioid exposure. And as Erin mentioned, this work has been supported by a CTR grant, a supplemental opioids grant that recently ended, and then we were funded with an R18 through the AHRQ in April of 2020. So are in year one of that grant. So I'm going to share a little bit of my work from both of those. Just a bit of background information. So pregnant women with opioid use disorder is sort of the focus of my research. They have a unique set of healthcare challenges across what I think of as a spectrum of care, kind of spanning preconception to infancy and early childhood. Most of the research on this patient population has really focused on the perinatal period, meaning their pregnancy care and care during their birth hospital stay. But we know there are important gaps in understanding their care and their outcomes after the baby is discharged home. This is just a graph showing the incidence of maternal opioid use disorder in the United States over the past 2 decades. We've seen a rise in the incidence of 4 or 5-fold. And of course, there's a disproportionate impact on births affected by Medicaid and substantial statewide variation. These things tend to be measured in terms of births, affected infants per 1,000 births. And that can range, from less than 1 to 1,000 to up to 30 to 40 per 1,000 live births. So significant variation. And there are many associated outcomes that have, for both mom's pregnancy as well as the baby after delivery, that have been associated with opioid use disorder during pregnancy. The mainstay of treatment is medication-assisted treatment. This is recommended by the ACOG for all pregnant women with opioid use disorder. And this has been shown to improve a range of outcomes, again, including maternal relapse and pregnancy outcomes, pregnancy care, as well as infant outcomes such as preterm birth, low birth weight, and neonatal abstinence syndrome, which is that sequelae that we see most commonly or most worry about in the newborn period. In addition to medication-assisted treatment, though, there is a need for comprehensive counseling and physical health care for these moms that really can't be understated. So high rates of comorbid depression or anxiety, physical and sexual trauma. There's a high risk of concurrent illicit or other substance use, and then poverty, homelessness. And so all of these social determinants of health surrounding opioid use disorder, I think, really have significant impacts both for their experience of healthcare and as well as their outcomes for both the mother and infant. And then I wanted to just highlight the significant issues of healthcare-associated stigma and criminality that also surround this issue, which can compound many of these other factors. So the MATER program at Thomas Jefferson University has been a really key partner for me in my research. MATER, you can see, stands for Maternal Addiction Treatment and Education and Research. This is an old program, so have over 5 years of experience, 5 decades of experience of serving pregnant and parenting women with opioid use disorder. And so it's really a leader in the field, and I'm lucky to be sort of neighbors with the MATER program and working closely with colleagues here at Jefferson. The treatment philosophy at MATER is trauma-informed care. So creating a safe and accepting space that helps to prevent re-traumatization of this already very traumatized patient population. Of course, the administration of medication-assisted treatment, but also providing a lot of wraparound supports for the mother and infant dyad. And there's an emphasis on mindfulness-based interventions to really address, again, stress, trauma, and mental health issues. This is a graph that comes from researchers in the MATER program that just demonstrates the high rate of adverse childhood experiences among women in this program. More than half experiencing 4 or more of these. And of course, the research on ACEs shows that there is a very tight correlation between things like substance use and poor child health and development with ACEs. So just pivoting quickly to the birth hospital care, this experience of birth hospitalization has been shown in this patient population to be associated with feelings of guilt and shame and fear of loss of custody. They have expressed frustration with and mistrust of the scoring assessments that are used for their babies to assess neonatal abstinence syndrome. And these issues around stigma and fear can impede their trust in healthcare providers and as well as their future engagement with care. Neonatal abstinence syndrome, many of you may be familiar with this. It's the cluster of symptoms associated with opioid withdrawal and can be really a spectrum of symptoms or spectrum of severity from very, very mild symptoms requiring no treatment to severe issues, including weight loss, dehydration, and seizures. So I'm going to just focus now on the bulk of my research area, which is kind of the primary care space. So I really do think I've come to really appreciate pediatric primary care as an opportunity to provide a lot of supports that these mother-infant dyads require in that post-discharge period, so after coming home from their hospital stay. You can see here I've listed many of the sort of programs and interventions that we would deploy in the primary care space. A lot of it is around evaluation and referral and providing information and also kind of support for these families. Things like lead screening and maternal depression screening and literacy promotion, these are universal programs that we would implement for everyone, but can really help bolster and support child development for families that are particularly at higher risk. This is the AAP schedule for recommended well child care. Again, with each of these visits, there are so many, especially within those first 2 years of life. I think of each of these as a real opportunity for partnering with families and giving them the resources and tools that they need. Of course, there are many of these social determinants of health that I mentioned surrounding opioid use disorder, which can really provide a lot of challenges in primary care, especially within the context of a 15-minute well child care visit. And so these are complex challenges, and I think it can often feel overwhelming as a provider to feel like you're trying to address these multiple factors in the context of a visit. So we have used our CTR funding, this supplemental opioids program, to provide some kind of background or supportive data for the importance of primary care optimization for this population. So this was a retrospective cohort analysis. We used data from PedsNet, and specifically within that, the Nemours primary care system. We pulled data from 35 primary care sites across Pennsylvania, Delaware, and Florida. And you can see here we had a rate of about 2% that were coded as having an exposure to intrauterine opioids. And we were sort of using that as a proxy measure for maternal opioid use disorder. And essentially what we found, and not surprisingly, is that these infants had a reduced risk of experiencing adequate or recommended well child care through both the first and second year of life. And when we looked at gaps in well child care, defined as more than two or more consecutive well child care visits, we found that they were 1.4 times more likely to experience that compared to a general sort of population. And these estimates were adjusted for a variety of kind of characteristics or factors that might be associated with adherence to well child care. And so I think this just was really descriptive and intended to support the notion that there are real barriers to care and missed opportunities to engage women in supportive services for their child. We've also engaged in work around eliciting perspectives on experience of pediatric primary care. This is one study that was published at the end of last year. That was a survey study, so we conducted a secondary data analysis of about 150 women who had completed surveys on their experience with care and their satisfaction with their pediatric primary care. All of the women in this study were participants of the MATER program. And what we found is that less than a third of participants had stated that in the last year that their pediatric provider had asked for their viewpoints and opinions as the parent of their child. Less than half said that they felt their pediatrician had spent enough time with their child. And only about a half said that the pediatrician seemed to know important information about their child's medical history. And so again, this really supported our sort of hypothesis that there are opportunities for refining and really optimizing well child care for this particular patient population. So again, the questions that have been driving our research currently: how do we better prioritize and address the needs of these families? How do we provide culturally sensitive care in the setting of substance use and trauma, which are really difficult, I think, issues for providers to sort of navigate? And then how do we collaborate effectively with maternal providers, such as programs like Mater, who are serving these families as well? So our AHRQ grant, which was again funded in April of 2020, the title of this grant is Group Well Child Care Intervention for Infants of Mothers and Treatment for Opioid Use Disorder. And I'm a co-PI on this with Dr. Vanessa Short, who's an epidemiologist at Mater in the Department of OBGYN at Jefferson. So this has been a really exciting and fun collaboration with our OBGYN colleagues. The objectives have been to develop a comprehensive group-based well child care model for this patient population, and then evaluate feasibility, acceptability, and ultimately efficacy for these mother-infant dyads. So what is group primary care? So this is based off of an existing evidence-based model of care called centering parenting. The basic idea is that 6 to 8 parents are grouped together with their similarly aged infants, and we would utilize a 2-hour visit rather than the typical 15-minute well child care visit. And the visit would include all of the routine assessments, immunizations, and screenings that we would provide in well child care, but also allow for kind of greater breadth of group discussion, interactive activities, and sort of an emphasis on maternal participation in her infant's care. So really trying to promote her important role, her key role in her infant's health. This is a quote from the Centering Parenting website that sort of speaks to the idea that many times these parents feel like having that peer support can really help to address isolation and sort of some of that parenting stress that accompanies having a young infant or toddler. And these are just some pictures of what group well child care can look like in other examples and other sites. So again, really focusing on kind of that group interaction and discussion. The research on this type of intervention has really been positive. It shows higher satisfaction ratings, both from providers and patients, and an increase in adherence to well child care and a greater parenting confidence and set of skills. But there really has not been research on the effectiveness of this for mothers with opioid use disorder. This slide, I won't go into the details for out of the interest of time, but we have pulled in a study team from multiple disciplines to really try to cover the kind of the various facets of this grant. It's sort of a multifaceted intervention, and we wanted to make sure that we had representation from the various disciplines. So we've really, again, this has been a really exciting collaboration with our colleagues at Jefferson. So just in terms of the 3 overarching aims are to, again, adapt this existing evidence-based model of centering parenting for our patient population and to use an implementation science framework to develop that. And then to study it in a cluster randomized controlled trial design. We'll be using a mixed methods approach to assess the reach, the delivery, and the fidelity of the intervention. And we would be conducting a longitudinal follow-up over an 18-month period for all enrolled mothers and infants. And the outcomes, the clinical outcomes that we would be assessing are well child care utilization and their experience of care, parenting knowledge, and then a directly observed measure of parent-child interaction. So this is our group well child care space that we have sort of kind of set aside for ourselves at the Mater program. This is already being utilized for other group activities at the Mater program. So we are deep in the process of figuring out the configuration and the logistics of implementing well child care in this space. And right now we're in AIM 1. So again, we're sort of getting through towards the end of year 1 of this grant. And this aim is all about developing and manualizing this group-based well child care model for this patient population. We are evaluating the relevance and the acceptability and feasibility for this target population through interviews with Mater participants, and then as well as some provider interviews as well. And the questions for these interviews are being derived from the Consolidated Framework for Implementation Research, which is essentially a guide that helps address questions, make sure that those questions will address these very specific outcomes around relevance, acceptability, and feasibility. So looking at things like the intervention itself, the setting, and the providers who would be providing this intervention. And so we have data collection in progress for this aim right now. And so in conclusion, maternal opioid use disorder warrants a comprehensive care approach, really, again, across that spectrum of care. And I feel like there's really an opportunity within pediatric primary care to play a key role, and it's sort of an understudied aspect of their care to date. And future research, including the research that we're embarking on now, should really focus on reducing barriers to care and increasing the effectiveness of care for this population. And I do believe that this could really warrant a paradigm shift in the way we think about preventative care for high-risk populations. And I think that's it. I wanted to acknowledge my co-investigators and other colleagues that were involved in the research that I presented. And I'm happy to take any questions.